Friends, today I'm going to be talking about heart blocks. Now, I'm always honest with you about what you need to know for NCLEX. I'll say, hey, you have to know this, or maybe this isn't so important. So I'm going to be honest and say you really don't have to know heart blocks to pass NCLEX. Can you get a heart block question on the NCLEX? You can, but you don't necessarily have to get it right. You do not have to get all the questions right on the NCLEX. You have to get the questions that are fundamental correct, but you don't have to get the higher level, all of the higher level questions correct. And that's because you have to show that you know what a new grad knows. You need to know what the average new grad knows. And I've worked enough with new grads to know that most new grads do not know heart blocks. Maybe they know first degree heart blocks, but even that is really super questionable. So I'm going to be honest and say you don't have to know this for NCLEX, but it's super fun to know. And if you plan to work in cardiac or with adults or in the ED, I suggest you know it, and it's super fun. So let's go ahead and get started. Hello, Clinic Review family. It's Dr. Sharon with Clinic Reviews, the home of the very best NCLEX review in the entire universe, in my opinion. And the GOAT himself, Mark Klimek, teaches the on-demand NCLEX review that you can get at clinicreviews.com. We also do small group tutoring that I am involved with, and I do small group tutoring once a month, so you can purchase a monthly access to our small group tutoring. I do it once a month, so you get 4 in a month. You get 4 tutorings in a month. Mark does 2 of them. I do 1 and Pete does 1. So that's how that works. And we also have our streaming at clinicreviews.com. Today, I'm going to be talking about heart blocks, first, second, and third degree heart blocks. I will be honest. I used to teach a telemetry class to new grads at a pretty large hospital system here in Ohio. And so I know what new grads know, even the ICU nurses, and they hire the best of the best into the critical care departments at the hospital system where I worked. They had a new grad externship that all the new grads, no matter where they were going to work, would go through. And most of them were required to take this telemetry class. And I'll be honest, heart blocks was the one thing that almost nobody knew anything about. A few of them did, but most of them didn't. There are many, many schools that don't even teach cardiac rhythms. So if you're looking for a video on cardiac rhythms and you're saying, Dr. Sharon, which one do I have to know for NCLEX? You need to know sinus rhythm, AFib, A-flutter, V-tach, V-fib, and asystole. Those are the ones you have to know. I'm going to put the link to those videos where I teach those rhythms in the description of this video so that you can access those if you want to. But today I'm going to be doing heart blocks. So what I want to do is I want to start out by talking about the basic electrical conduction through the heart. Again, I have other videos where I spend more time on this, so this is going to be a super quick explanation of this. Right here, we have the SA node, the sinoatrial node. The SA node is a bundle of cells that can spontaneously depolarize, and they depolarize at a rate of between 60 and 100. So the electrical rhythm always starts in the SA node. It travels down the electrical pathway in the atria, and as it travels down the electrical pathway, sort of like a wave in a lake, if you throw a rock into a kind of a clear lake, and you'll see it kind of wave out. That's the same thing that it does here. It kind of waves out into each side of the heart, into both atria, and then it gets here to the AV node, the atrioventricular node, which is between the atria and the ventricles, which is why it's called that. Then it travels down here through the right and left bundle branches and out into the Purkinje fibers. So that's how it travels through the heart. It starts in the sinus node, goes down to the AV node, down each side of the bundle branches and out into the Purkinje fibers. So that's how that electrical conduction works. And when you think about rhythms, the first word of the rhythm tells you where that rhythm starts. So a sinus rhythm starts in the sinus node. Okay, so a sinus rhythm, a sinus bradycardia, sinus tachycardia starts in the sinus node. Atrial rhythms, atrial fibrillation, atrial flutter, atrial tachycardia, they start somewhere in the atria, not in the sinus node. Okay, and we want the sinus node to be in control. Y'all, the sinus node is the best friend you're ever going to have. It beats regularly 60 to 100 times a minute for like 100 years. Your sinus node ain't no better friend than that for you. So you want your patient to be in a sinus rhythm. So when we see an atrial rhythm, we go, why isn't the sinus node in charge? We try to get the sinus node to be back in charge if we can. They can live in an atrial rhythm if they have to. It would be better not to because the sinus node is much more reliable, but they could have an atrial rhythm. I'm not going to talk about junctional rhythms because junctional rhythms are pretty unusual in real life, and I really don't think you're going to get tested on it. I mean, I think there's about a 0% chance you're going to get tested on a junctional rhythm on the NCLEX. And then it can go down into the ventricle. So it can go down each side of the bundle branches. It goes down the right and the left side at the same rate and then out into the Purkinje fibers. So ventricular rhythms, VTAC, VFib, these are rhythms that are initiated in the ventricles. So what we're going to be talking about today are heart blocks. Heart blocks are generally either sinus or atrial rhythms. They almost always are sinus or atrial rhythms. And they're going to be kind of defined as such. So we do want to look and see where the rhythm is starting. Does it have a normal P wave? And as far as the P wave is concerned, the P wave looks like what everybody knows a P wave looks like. Okay, this is the P wave. It's upright, it's slightly rounded, and you know what a P wave looks like. So you say, if the P wave doesn't look like that, then I know it's not a sinus rhythm. So we look at this and we go, how do you know it's a sinus rhythm, Dr. Sharon? Because there's an upright rounded P wave followed by a narrow QRS and then an upright rounded T wave. The T wave's a little bigger than the P wave. It should be, because they represent different things. The P wave represents atrial contraction. The T wave represents ventricular repolarization. And so they do look slightly different, but you're going to have an upright rounded P wave, fairly small, a larger QRS, which represents ventricular contraction or ventricular depolarization, followed by a T wave, which represents ventricular repolarization. So that's what a P wave looks like. So when we talk about heart blocks, most of the heart, well, I would say all the heart blocks we're going to look at are going to have a normal P wave. So then what in the world is a heart block? A heart block is where there's a block somewhere in the electrical conduction. So there could be a block between the SA node and the AV node. If there's a block in the electrical conduction between the SA and the AV node, that's called a first degree heart block. It means it's slowing it down. I want you to imagine you're driving through a road and all of a sudden it says there's construction ahead and it's going to be a 1-lane road. You're on a 4-lane highway, but now your 2 lanes on your side is going to go down to 1 lane. What happens when you go down to 1 lane from 2 lanes? Well, it slows everything up, right? Because everybody's trying to merge over onto the one side. And sometimes you actually have to stop and you're sitting there, oh, good grief, right? I'm trying to get to work. And so this construction slows it down. So that's what a first degree heart block is. It's a slowing down of the conduction between the AV and the SA and the AV node. It slows it down. And so it takes more time to get from the SA node to the AV node. That's a first degree heart block. A second degree heart block is where your SA node is firing just fine, but there's some kind of block in the junction. So it hits the junction, and sometimes the electrical conduction gets through the junction, and sometimes it doesn't. And sometimes it gets through the junction, but sometimes it just takes longer and longer each time. So it hits the junction and it goes through. The next time it hits the junction, but it takes longer to get through there. The next time it hits the junction, it takes even longer. And the next time it doesn't get through at all. And then the pattern starts all over again. So that's one type of second degree heart block. Another type of second degree heart block is where it hits the junction and it does not go through. Hits the junction, does not go through. Hits the junction, this time it goes through. And then it does it all over again. Hits the junction, doesn't go through. Hits the junction, doesn't go through. Hits the junction, this time it goes through. So it's sort of like taking a hammer to something, right? You hit it and you're like, okay, it didn't, the hammer didn't get the nail all the way in. So I got to hit the nail again. And this time it went in mostly, but not all the way. And you hit it again, and now it goes in all the way. And then you go to your next nail and you hit it. It goes in halfway. You hit it again. It goes in 3/4 of the way. You hit it again. It goes in all the way. You go to the next nail. You hit it. It goes halfway in. You hit it again. It goes 3/4 of the way. And then you hit it again. It goes all the way through. So that's a second type, a type 2 second degree heart block. And then a third degree heart block is where the electrical impulse hits the junction. It doesn't go through. It keeps hitting it. Bam. In fact, it hits it the regular 60 to 100 times a minute. It never goes through, y'all. It just completely doesn't go through. So you have P waves. But the interesting thing about this rhythm is that the ventricles then take over on their own. The ventricles are like, hey, where's the impulse? We're waiting. Where's the impulse? Come on, we're waiting. You're not going to send me an impulse? All right, I guess I'll just go ahead and fire on my own. And the ventricles end up firing on their own. So it's a disconnect between the P wave and the QRS. Remember, the P wave represents atrial contraction and the QRS represents ventricular contraction. So here we have a PQRST, 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 PQRST. That's a sinus rhythm. The sinus node hits the AV, it goes through the ventricles contract, and it goes again. Atrial, ventricles, atrial, ventricles, atrial, ventricles. So that's a sinus rhythm. So let's go ahead and look at these. But just to remind you again, a third-degree heart block is when that P wave and that QRS are completely disconnected from each other. So this is normal sinus rhythm, okay? All right, so let's look at this. Now, what I have is I have an electronic calipers. If you want to get an electronic calipers, you can download it. It's an app. It's called EP Calipers. I don't get any money from it, y'all. I'm just telling you because people always ask me, where'd you get those? Okay, so here we have the beginning of the P wave. And so what we want to do is we want to measure the PR interval. And I talk about PR intervals in another video. So here we have our PR. Okay, so the beginning of the P to the beginning of the QRS is the PR interval. And so what we're going to do is we're going to count boxes. 1, 2, 3, 4, 5, 6, 7, 8. There's 8 boxes, and each box is 0.04. So 0.04 times 8 is 0.32. If you're like, Sharon, I can't remember that, just go 4 times 8. 4 times 8 is 32, and then put a decimal point in front of it, okay? So our PR interval is 0.32. Now I'm going to go to the next one and see. Y'all, if I go to the next one, it's the exact same interval. There's no changing it. So the PR interval here is the same. I got to move my whole caliper over. The PR interval is the same. The PR interval is the same. And if I go along, I'm going to find that the PR interval is the same all the way along. Okay. So I have a PR interval of 0.32. What is the PR interval supposed to be? The PR interval is supposed to be 0.20 or less. Okay. 0.20 or less. So I have a long PR interval. That means it's taking longer. It's taking longer for the electrical impulse to get from the atria, which is the P wave, to the ventricles, which is the QRS. So it's taking longer. So where's the block? The block is somewhere between the SA node and the AV node. So we have a long, it's like getting stuck in construction traffic. Remember, we talked about that. We said you have 2 lanes, you go down to 1, and everybody has to slow up, and it's taking longer, and you're like, oh. And that's a first-degree heart block. Now, how do we describe that then? So a first-degree heart block is a long PR interval, but it looks, look at it, it looks like a sinus rhythm. It looks like a sinus rhythm. You got a PQRST, 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 PQRST. You're not missing anything. You just have a long PR interval. So this is called a sinus rhythm because that's what it is. You have the sinus node is in control here. You have a sinus rhythm, but it's just taking longer to get through the junction. So it's a sinus rhythm with a first-degree heart block. That's how you describe this, okay? This is very common, very, very common, at least in the hospital. I don't know how common it is outside the hospital. I don't know what the percentages of people with first-degree heart blocks, but I do see it on a fairly regular basis. I would document it. I would make sure the physician was aware of it, but I don't expect any treatment for this. These are generally asymptomatic. They're usually not clinically significant. What could cause a delay between the AV and the SA and the AV node? What could cause a delay? Could be electrolyte imbalance. Maybe I'll look at their electrolytes. It could be some previous cardiac damage. It could be illness. It could just be their rhythm. So this is the kind of thing where we seldom do anything about it. I would look for any causes. I would look at their electrolytes. I would look at their hydration status. I would look and see if they have a history of heart disease that could have caused some damage to that electrical pathway that could have slowed it down a little bit. Other than that, we generally find that these are asymptomatic and we don't do anything about it. All right, this is another example of a first-degree heart block. So I just want to show you here. So I'm going to bring my calipers over. And I'm going to go ahead and measure from the beginning of the P to the beginning of the QRS. So let's see how long this is. So 1, 2, 3, 4, 5, 6 boxes. 6 times 4 is 24, so 0.24. And I want it to be 0.20 or less. And it's long, so my PR interval is long. So let's go ahead and see if my PR interval is consistently long or if it's changing. So there it's the same, there it's the same, there it's the same, there it's the same. So my PR interval is the same. And you might go, well, Sharon, it looked like there was a half a box difference. I don't care about a half a box difference. I only care if it's about 2 boxes or if it's consistently getting longer. If it's consistently getting longer, I care. But if it's the same within 2 boxes or maybe 1 box for PR interval is usually pretty consistent. So I would say unless it's a full box or more different, I don't care about that because sometimes these things, depending on how they're breathing and so forth, can change things a little bit. But the PR interval is usually quite consistent. So it's long. So what is this rhythm called? If you were to chart what this rhythm is, you would chart that this is a sinus rhythm with a first degree heart block. Okay, sinus rhythm with a first degree heart block. That's how I would describe this. So let's go on to the second one. Oh, good grief. I did another sinus rhythm. All right. Sinus rhythm with a first degree heart block, Sharon. I was really overdoing the sinus rhythms with the first degree heart blocks here. All right. So here again, we have a PQRST, 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 PQRST. We've got a consistent sinus rhythm because we have a nice upright P wave. Now we got to measure our PR interval. So I've got my calipers there. 1, 2, 3, 4, 5, 6, 7. I'm going to say 7.5. Let's make it easy on me. I'm going to say 7 boxes just to make it easy on me. So for the math. So 7 times 4 is 28. So that's, and then put a decimal in front of it. That's 0.28. And that's seconds. That's a quarter of a second. I know that's really fast, y'all. You might go, a quarter of a second. How's that a first degree heart block? Things happen in the heart really fast. I mean, really fast. I'm telling you, your sinus node is the best friend you're ever going to have. So the sinus, it's taking a little more than a quarter of a second to get from the SA node through the AV node and into the ventricles. And I say, well, that seems fast. And I say, not quite fast enough, y'all. It happens really, really fast. I mean, you've got to get 60 to 100 beats a minute through the heart. You got to get 100, you got to get a 60 to 100. And if it takes more than a quarter of a second, you're going to have a hard time getting that many beats through. All right, well, I will digress. So here we have our PR interval is the same there. The PR interval is the same there. The PR interval is the same there. And then I go over one more and the PR interval is the same there. So we have a sinus rhythm with a first degree heart block, sinus rhythm with a first degree heart block. Okay. All right. Let's see if I actually did a different rhythm now. All right. I finally did a different rhythm. All right. This is a second degree heart block type 1. It's also called a Wenckebach. Second degree type 1 is a Wenckebach. So remember this phrase, longer, longer, longer drop, then you've got the Wenckebach. Longer, longer, longer drop, then you've got the Wenckebach. Longer, longer, longer drop, then you've got the Wenckebach. This is a second degree type 1, but I do think what they'll do is if they say second degree type 1, they'll put in parentheses Wenckebach because that they are consistently called both things. Okay. So how do you know if you have a Wenckebach? So you look at this and you say, well, I have P waves. Where are my P waves? Well, let's see where the P waves are. Let's see if I can show you where the P waves are. All right. So here's a P wave. Here's a P wave. Just going to circle the P waves here. Okay, so I circled all the P waves. So let's go ahead and see if our P waves are occurring regularly. Okay, let's see if our P waves are occurring regularly. So what I'm going to do is I'm going to measure P to P. P to P. And when I measure P to P, I go in the middle of the P. You can go at the beginning. I just happen to go in the middle. Okay, so there's my first P to P, and it's that long, however it is. You don't have to measure it. And then I go to my second one and I go, well, it's about the same. You might say, well, it's about a box different. No, okay. I said it has to be more than a box or I'm not worried about it. And then I go to my next one and I say it's about the same P to P. I go to the next one, it's about the same P to P. And I go to the next one, it's about the same P to P. So I have a regular P wave. Bam, 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 Remember I said your sinus node is your best friend. So you've got this sinus node that's going, hey, I'm doing my job. I'm firing, right? It's all good. You go, okay, thank you, sinus node. I love you, sinus node. Thank you for doing your job. All right, so now what I'm going to do is measure my PR. So from the beginning of the P to the beginning of the QRS is that far. So how many boxes is it? 1, 2, 3, 4, 5, 6, a little over 6 boxes. I don't know if you can see this, but right here, for some reason, this caliper tells me it's 92 points. I'm going to go with this number and see if this number gets higher. So it says 92 points. I'm going to measure the next PR and see if it says more than 92 points. I don't know what this 92 points means. I just know that it gives me this. All right, so now it went up to 108. Okay, the number went up to 108. Let's go to the next one. Next PR interval, I have to, let's see, it looks like this one is about the same. So it's about 108 still. And then this one, oh, this one's even longer. So now I have to go, all right, so now it takes it up to 125. So it started out in the 90s, it went up to 108, and then it went up to 125. So it's getting longer. So longer, longer, longer. And then I go to my next one. And all of a sudden, where the QRS is supposed to be, there's no QRS. You notice how there's no QRS there? So I went longer, longer, longer drop. Then you've got the what? Then you've got the Wenke Bach. All right. So all of a sudden, I'm dropping a QRS. Now I'm going to go to the next one. And all of a sudden, I'm back down again to 96. All of a sudden, I'm back down in the 90s again. So it didn't just stay long. It goes longer, longer, longer drop. And then it goes back down to what the first PR was. Okay. And then it gets longer, longer, longer drop. And then it goes back down to what the original PR was. So we've got longer, longer, longer drop. So we have an upright rounded P wave and we have a normal QRS, but we dropped a QRS. This is the second degree heart block type 1, which is a Wenke Bach. Okay, I think I have one more. So here, let me go ahead and look at this, because what I do is just by looking at it, I think, wait a minute, those P waves look normal. They're upright and rounded. The QRSs look normal, but it seems like I'm missing a QRS. So let's see, are we missing a QRS? Well, let me go ahead and highlight where we're missing a QRS. So it seems as though we are missing a QRS right here. Okay, this is where I expect there to be a QRS. So let me go ahead and circle my P wave. So here I have a P wave, another one. Oops, that didn't quite go right. All right, so I have all these P waves. So my P waves appear to be normal. My sinus node is going, hey, I'm doing my job. I'm doing my job. Stop giving me a hard time. It's fine. I'm doing what I'm supposed to do. All right, well, let's go ahead and measure from P to P. Let's see if the P to Ps are occurring regularly. Oops, I just measured my P to R. So first I'm going to measure my P to P. So I go from the middle of one P to the middle of the next one. And I'm going to go along and say, are they occurring regularly? Well, my first P to P is however long it is. And I don't know if it gave me a number. It's 245 points is what it's saying. And again, I don't know what the points means. I'm just going, this calipers gives me a point thing. I don't know what that means. So it's 245. How about the next one? The next one's the same distance. So even though I'm missing a QRS, my P to P, my P's, my sinus node is firing regularly. Do you see that? So my P to P, these are firing regularly. So now the question is my PR the same? What does my PR look like? So let me go ahead and measure my PR. So here, and I'm going to just do the points again because I'm not going to bother with the counting boxes. This one says, what is this? I can't tell. It says 51 points. Okay. So it says 51 points out. The box 1, 2, 3, 4.5 boxes approximately. So let's go to the next PR. So I'm measuring my PR. Okay, well, this one's definitely longer. Now it's 91 points from the beginning of that P to the beginning of the R. Let's go to the next one. Well, this one's definitely longer. Now we go up to 106 points. And then I go to my next one, and where my QRS is supposed to be, there is no QRS, y'all. I'm missing a QRS. And then I go to my next cardiac complex here, and my PR goes back down to, what does it go down to? It goes down to 54 again. It goes down to 54. And then I go to the next one, and it's longer again. So my PR is longer. So I have longer drop. And if you have longer drop, what is that called? Well, that's called a Wenke box. So I have a second degree heart block type 1. Second degree heart block type 1, which is a Wenke box. All right, let's do this. Let's do another one. So a first degree heart block, sinus rhythm with first degree heart block, just has a long PR interval. Every cardiac complex has a P wave, QRS, and T. You just have a long PR interval. And then a second degree type 1, which is a Wenke box, you go longer drop. So your PR gets longer, and then you drop a QRS. And then it goes back to the PR is now normal, and it gets longer, and then you drop. Okay. So it's that patterned longer drop. Now here we have something that looks a little different. And it does look a little more serious. I don't know if you think it looks more serious, but it does to me. I have a lot fewer QRSs, but I still have this upright rounded P wave. I go, well, my P waves look fine. And my sinus node is talking to me saying, hey, I don't have a problem. This sinus node, I'm doing my job. Y'all, I'm your best friend. You know, I'm your best friend. I'm firing just like I'm supposed to be firing. And you're like, you sure are. Those P waves look just fine. They're just fine. And if I were to measure them, I'm not gonna what I call marching them out. Well, you know what? I will. You can fast forward through this if you don't need me to do it. So just fast forward through this part if you're like, I don't need you to march out those P waves, Sharon. Okay, so what I'm going to do is I'm going to march out my P waves. I'm going to show you the P waves are occurring regularly. So from the first P to the second P is this 149 points. From the second to the third stays about the same. From the third to the fourth is the same. Fourth to fifth is the same. Fifth to sixth, same. Sixth to seventh, same. Seventh to eighth, eighth to ninth, ninth to 10th. So my P waves are occurring regularly. My sinus node is saying, dude, I'm doing what I'm supposed to be doing. You told me I'm supposed to fire 60 to 100 times a minute. I'm firing 60 to 100 times a minute. It's not my fault. So the question is, where is the block? Because it's not making it all the way through to the ventricles. It's only making it all the way. It takes 3 pounds of the hammer before it gets through. Remember I told you sometimes if you're pounding a nail in, you pound that nail in and you have to pound it and it goes halfway through and then it goes 3/4 of the way through and then all of a sudden it goes through. And then you pound the next nail in and you pound it halfway in, but it doesn't go all the way in. You pound it 3/4 of the way in. And then the last time you pound it, it goes all the way through. This is a second degree type 2. This is where it takes several pounds of the hammer to get it through. So you have multiple P waves for every QRS. This has 3 P waves for every QRS. The interesting thing about this, and I don't know why it happens this way, it's a very interesting phenomenon, is the PR interval stays the same. Okay, so the PR interval here is 38 points. The next PR interval is 38 points. Again, I'm doing this because this is my calipers tells me. I don't know what it means. This one is 38 points. This one is essentially 38 points, maybe a little bit longer, but it's 42 points. It's essentially the same. It's not a full box difference. So the PR interval stays the same, but it takes 3 pounds of the hammer. So when you describe this, you always say kind of what your ratio is. Now, I don't say it here, but if you were a nurse working in the hospital, you would say it's a 3-to-1 ratio, 3 P waves for every QRS. Now, would I want you to have this short of a rhythm strip for your patient? No, I'd want you to print out a long rhythm strip so we could really see if this was happening consistently or was it just a short period of time that this was happening. But this is something that you would say, what's the ratio? How many pounds of the hammer does it take before it goes through? And then you would describe this as a second degree heart block type 2, a second degree heart block type 2. This is more dangerous than the Wanky Bach because Wanky Bach, I'm going to go back to it. Wanky Bach has more QRSs. So this is a 6-second strip. So my QRSs are 1, 2, 3, 4, 5, 6. I have 6 QRSs in 6 seconds. That means the heart rate's about 60. Because it's the ventricle contraction that makes sure the blood gets out of the heart. So if the ventricles aren't contracting, y'all, you have no cardiac output. So here we have a rate of 60. So this person might not even realize they have a cardiac dysrhythmia. They may feel perfectly fine. As opposed to this person, this is also 1, 2, 3, 4, 5. This is also a 6-second strip. Well, how many QRSs do we have in this strip? We have 4 QRSs. So their heart rate, y'all, if you were checking their pulse, you would only count 40 beats per minute. And it's not a sinus node problem. The sinus node is going, don't blame me, I'm firing just fine. There's a block somewhere. Remember, we looked at the heart. It has to go from the SA node down to the AV node, down the Purkinje, or down the right and left bundle branches and out to the Purkinje fibers. So our sinus node is doing what it's supposed to do, but it's getting blocked somewhere before it reaches the ventricles. It's usually somewhere in that junctional area that it's getting blocked, and it's taking 3 pounds of the hammer to get through. So a first-degree heart block, sinus rhythm first-degree heart block, has a long PR interval. Second-degree heart block type 1, which is the Wanky Bach, is longer drop. And then a second-degree heart block type 2 is where it takes multiple pounds of the hammer to get it through. And so you have this disparate number of P waves to number of QRSs. Here we have 3 P waves for every QRS. All right, this is also a 6-second strip. This right here, this line is the middle of the 6-second strip. So we've got 3 seconds before and 3 seconds after. So how many QRSs do we have? Well, we only have 4 QRSs here. And so if we only have 4 QRSs, we know the heart rate's only 40. Well, how many P waves do we have? Well, let's go ahead and look at our P waves. So we have a P wave up here. I don't know if you can really see it. I'm just going to circle them instead of just talking through the whole thing. So in this case, we have 2 Ps for every QRS. Now it does look like our Ps, our sinus rhythm is a little slower maybe. But if I were to count how many P waves in this 6-second strip, 1, 2, 3, 4, 5, 6. Actually, there's 8 Ps in this 6-second strip. So the sinus node is firing at a rate of 80 because those P waves are firing 8 times in 6 seconds, which means it's occurring 80 times in a minute. Multiply it times 10. So we have a normal sinus rate here. The sinus rate is fine, but it's taking 2 sinus beats, 2 sinus cracks of the hammer on that nail to get it to go through. And so we do have a QRS. It does have a bundle branch block, which I'm not going to go into what that is because that's not what I'm talking about today. But let's make sure our P to P is occurring regularly. So we have a P to P, middle of one P to the middle of the next. That's the same. So these are marching out. The P waves are marching out just fine, y'all. That one's a little bit shorter, but generally they're occurring pretty regularly. Okay, so that sinus node is firing pretty regularly, but it takes 2 pounds of the hammer to get through. So our ratio is 2 to 1 for sinus beats compared to ventricular beats. So I'm going to look at my PR interval. Now, in this case, my PR interval is really long. Okay, this is a very long PR interval. It's actually 1, 2, 3, 4, 5, 6, about 7. So it's about a 0.28. But because it's a second-degree heart block type 2, we don't bother to talk about it's a first-degree heart block as well. So you can say, well, it's a first-degree heart block and a second-degree heart block. And I'd say, you're right. It's actually a first-degree heart block, a second-degree heart block type 2, and a bundle branch block. It's got all 3 of those things. And you can tell that because you can see that little notch in the QRS. The bottom of the QRS has that notch in it. And that is essentially telling you right here, this notch, that's essentially telling you that there's a block in those bundle branches. One of those bundle branches has that going on. Nevertheless, It actually has all three, but our PR interval is long, but it's a second degree type 2 because it takes 2 beats of the sinus node, two hits of that hammer to go all the way through. So I'm just going to make sure my PR interval stays the same. So there's my second PR interval. It's the same as the first one. The next PR interval is the same as the first one. And then the next PR interval is the same as the first one. So my PR interval is staying the same. It's just taking 2 pounds of the hammer to get that to go through the AV node. So I have a second degree heart block type 2. Okay, now we're going to get into our complete heart block, our third degree heart block. And if you feel like your brain is exploding right now, you may not want to continue the video. You may want to just work on those first and second degree heart blocks. Third degree heart blocks, generally speaking, you're going to see in the ED primarily because people don't survive in third degree heart blocks for very long. It's an emergency situation. The second degree type 2 usually requires a pacemaker, and the third degree heart block always requires a pacemaker. That's why you don't see them on the floor very often, because you see a paced rhythm. Maybe I'll do a video on paced rhythms because they are kind of interesting. Nevertheless, this does require an emergency pacemaker. So usually what they'll do is they'll do an external pacemaker until they can get them to essentially to the OR to put in a permanent pacemaker. So how do I know? Well, let me go ahead and circle all of my P waves here. So I look at this and I say, okay, where are my P waves? And this is the thing is you can't, it's hard to tell because they occur regularly. Here's another one here. I know this is one. And I'm pretty sure this is one. Okay. I'm just looking for something that looks like the P wave. So I'm going to circle this. It looks like that's one. And I'm not sure, but I think this might actually be one here as well. So what happens is you say, well, that doesn't make much sense. That's weird. That's like weird how that looks. And I say, you are so right. That is so weird how that looks. So I'm going to measure between two P's that I know for a fact are P waves. Like I know for sure that these two are P waves here. And so and with a third degree heart block, my P waves are still occurring regularly because the sinus node is still firing. The sinus node is looking at me going, I'm doing my job. Look, I'm your best friend. I'm firing just fine. The problem is there's a block between the atria and the ventricles, and so nothing can get through. So I know those two are P waves. So if I go ahead and go along, then I say, well, that's close. I thought that was a P wave, and it's really super close. So I would say, yeah, that's probably a P wave. Now, if I measure from that one to the next one, I say, you know what? I was right. That actually is a P wave. Let me go to the next one. Do you know what? I wasn't sure if this was a P wave, but it turns out that it is. So I'm going to go ahead and circle that so that I don't forget that that was a P wave. So I go, that was actually a P wave. I didn't realize that. So now I'm going to go ahead and measure, and I go, it's a little bit off, but it's pretty close. And then I go from here to here, and I go, yeah, that's a P wave. And then I go from here to here, and I say, you know what? That is also a P wave. I wasn't sure, but that is also a P wave. So I'm going to go ahead and circle that. And I think the reason it looks different is I think it's combined with the T. I think the P and the T are kind of combined because remember, there's no relationship between the atria contracting and the ventricles contracting. So the atria and the ventricles can contract on top of each other. And so this actually turns out to be a P wave here as well. If I were to march them out, I would find that that was the case. And then this turns out to be, okay, so that turns out to be a P wave as well. So what you can see is there's absolutely zero relationship between when the atria contract and when the ventricles contract. And you can tell that just by eyeballing it. Most of the time, you can identify a third degree heart block just by eyeballing it. It's so clear there's no relationship between the P and the QRS. I'm just circling the QRS so you can see. how that is. And if you just by looking at it, just by eyeballing it, those QRSs are occurring regularly. So what happened is the ventricles are waiting for that electrical impulse from the atria, and they're never getting one. It's never coming through. And so they decide to just beat on their own. They're like, I guess I'll just beat. I'll just go. So that's what happens. And this is let's see, that's 1, 2, 3, 4, 5, 6. This is about an 8-second strip. So the heart rate here is probably between 30 and 40. If we were to actually check a pulse, we'd find that the heart rate is between 30 and 40. But the P waves are occurring regularly, and there's absolutely zero relationship between the two. Sharon, that was just too much. I don't know if I can handle this. Then it's okay. Just focus on the first and second degree heart blocks. Third degree heart blocks, the students that I try to teach this to did struggle with this. Okay. You have to really understand normal sinus rhythm, AFib, A flutter, VTach, and VFib. Those are the ones you have to know. So again, I'm putting the link to those videos in the description. So don't let this stress you out too much. Okay, let's do one more. And if we look at this, it's really ugly. Like this is, you just look at this and you go, this person cannot be doing very well. And I would say, you are so right. This person cannot be doing very well. No joke here. Okay. So I'm going to circle my P waves. We're going to assume this is this is not an emergency, and we have time to circle all our P waves. Because y'all, if they came in through the ED and this is what you saw, you'd go, bring the crash cart. Please bring the crash cart, because I don't know what's going on here. And what you see is you have this, I'm not even sure where the P wave is. The P wave, as far as I can tell, is probably occurring right in here somewhere, which is why you cannot see it. And I think this actually might be a P wave right here. So if we were to march out our P waves, I think what we would find is that they are occurring regularly. And the sinus node might say to me, I'm doing my job. I'm firing just like I'm supposed to. And I'd say, you're right. You are. Thank you for doing that. But it's not getting through. So my first P, I know those are both P. So I'm going to measure it from the P to P. I do it from the middle to the middle. So let's scoot it over and see if it falls here. So it falls pretty similarly. So between this P and this P. So I am pretty confident this is a P wave. And then I go over and I say, yep, that's a P wave, because it marches out regularly. And then if I go over one more, see, I thought that was a P wave and I was right. And I know it is because I'm marching it out using my calipers. And remember, the sinus node fires regularly. I told you it's your best friend. It fires regularly. Even when the electrical impulse doesn't go anywhere, it's still going to fire. And so again, I'm marching out my P waves and I go, yep, there it is. And there's another one. It's marching out just fine. The sinus node is doing its job. Now this one, I was wrong about where the P wave was. This is actually the P wave over here. So let me go ahead and fix that. Actually erase this one and circle where it actually is. So it's actually right here. Okay, that's the P wave right there. And I know that because I was marching it out. Okay. Now you should be able to tell just by looking at it. There's no relationship between the P's and the QRSs. In this strip, it has 1, 2, 3, 4, 5, 6, 7, 8 P waves. And in this strip, it only has 3 QRSs. There's no relationship. And if I were to measure my PR, y'all, the PRs they're not getting longer drop. There's no pattern there. I would need a longer strip to prove that to you, but there's no pattern there. And then I can't say, well, every time it has 2 Ps to every QRS, because in the second QRS, it's on top of it. The P is literally on top of the QRS. Y'all, if you ever have a strip where the P is on top of the QRS, that's a third degree heart block, because that's not supposed to happen. Okay. So this is actually another third degree heart block. And if you were working in the ED and you saw this, you would say, doctor, we've got a third degree heart block. Let's get the crash cart in here. We're going to do X. You're going to put the pads on them and you're going to pace them using the pads until they can get them into surgery to give them a permanent pacemaker. So that is a second and third degree heart block. Now let's go ahead and ask you some questions, because you might say, well, this is a little overwhelming. And I would say, yes, I understand that. It's a little overwhelming, but let's do some questions so that I can at least show you that you could answer the questions correctly if you need to. Okay, so if you happen to get these questions, or what is it you really need to know about this? So a nurse is reviewing an ECG strip of a patient diagnosed with a first degree heart block. Which of the following characteristics should the nurse expect to observe? PR interval less than 0.12, PR interval greater than 0.20, variable PR interval, absence of P waves. So a PR interval less than 0.12, that's not really anything particularly clinically significant. So we're going to cross that one off. A long PR interval greater than 0.20, that's a first degree heart block. Variable PR interval duration, that's more of a wanky block. And it also could be a third degree heart block. And absence of P waves, that's something else entirely that we have not talked about. So the correct answer is a PR interval greater than 0.20. A patient with a history of hypertension and diabetes is diagnosed with first degree heart block. Which of the following statements by the nurse indicates a correct understanding of this condition? It means there's no atrial contraction. False. There's a P wave, so there's atrial contraction. Okay, if there's a P wave, the sinus node is firing, you've got atrial contraction. The condition typically requires a pacemaker. False. A first degree heart block does not require a pacemaker. It often presents with a prolonged PR interval on the ECG. That is true. That's what a first degree heart block is. The ventricles are contracting more frequently than the atria. False. None of the heart blocks have the ventricles contracting more frequently than the atria. None of the heart blocks. That's not true for any of them. So C is the correct answer, has a prolonged PR interval. A patient presents with an ECG showing progressively lengthening PR intervals until a QRS complex is dropped. Which type of heart block does this pattern indicate? Longer drop, then you've got the what? Then you've got the wanky block. Okay, so we've got progressively lengthening PR intervals. That's the longer until a QRX is dropped. Longer drop. Now, I didn't give it away here. I wanted to see if you can remember which type of heart block it is. It's the second degree type 1. I do think on the NCLEX they would put wanky block after it's the second degree type 1, so that you'd be able to remember that, because it's not easy to remember the difference between type 1 and type 2. But if they say wanky block, I can always remember it, which is probably why they use that term now, to help people remember which is which. A nurse is monitoring a patient with a second degree heart block type 1, which is a wanky block. Which of the following interventions is most appropriate for managing this condition? Immediate administration of atropine, preparing the patient for immediate pacemaker, administering a beta blocker, continuous ECG monitoring and observation. The correct answer is continuous ECG monitoring and observation. They don't tell us what the heart rate is, so I really don't want to give either atropine or a beta blocker. Beta blocker slows the heart rate, so I'm really not going to give a beta blocker. That would be completely contraindicated with a heart block. So I'm not giving a beta blocker. Atropine, I'm not going to give unless I know what the heart rate is. If the heart rate is 30, then yeah, I'll give atropine, but I don't know what it is. And so, and it rarely requires a pacemaker. Sometimes it does, but it rarely does. So I told you with the wanky block, if the ventricular rate is between 60 and 100, they're just going to monitor them, just going to keep an eye on them and see how they're doing. So, and wanky blocks tend to have higher ventricular rates than the second degree type 2. A nurse is caring for a patient with a second degree heart block type 2. Which of the following findings should the nurse expect on the ECG? So this is the one where you have to hit the hammer multiple times before the nail goes all the way in. Constant PR intervals with intermittently dropped QRS complexes. Constant PR intervals. So in a type 2, second degree type 2, it does have a constant PR. And it does have intermittently dropped QRSs. So that's a true statement about type 2. Gradually lengthening PR intervals followed by a dropped QRS. Gradually lengthening, longer with a dropped, that's wanky box. So that's type 1. So B is not correct. PR intervals less than 0.12, that's nothing we talked about. P waves and QRS complexes occurring independently of each other. That is a complete heart block, or a third degree heart block. Complete heart block has no relationship between the P's and the QRSs. So the correct answer here is the constant PR intervals with intermittently dropped QRSs. Which of the following statements by the nurse indicates a correct understanding of the management of a patient with second degree heart block type 2? This is the one where it takes multiple pounds of the hammer to get it in. It would be nice if we knew what the ratio was, like a 3-to-1, 4-to-1, 2-to-1, whatever. It's never going to be 1-to-1. If it was 1-to-1, it wouldn't be a second degree heart block. So it's going to be 2-to-1, 3-to-1, 4-to-1. So which is the correct understanding of the management of this type of heart block? This condition usually resolves without treatment. That's false. We will need to prepare the patient for potential pacemaker insertion. That's true. It doesn't say we're going to do a pacemaker. It doesn't say it's an emergency, but we do need to prepare in case that's what they want to do. Beta blockers are the first line of treatment. That slows heart rate, y'all. Don't give a beta blocker to someone with a heart block. Absolutely 100% contraindicated. It's typically less severe than second degree type 1. That's false. Type 2 is more severe than type 1. So we will need to prepare the patient for potential pacemaker insertion. Remember, the right answer is the right answer because of the other answers. If it's said on there, we need to monitor them closely, I would say that's also a right answer. I would monitor them closely, but we don't have a monitoring them closely option. The other three are wrong. Okay, D is absolutely wrong. C is absolutely contraindicated, and A is absolutely wrong. So the only one that makes any sense is we may need to give them a pacemaker, which is a true statement. We might have to do that. A nurse is reviewing an ECG strip of a patient diagnosed with a third degree heart block. So this is a complete heart block. Third degree is a complete heart block. There's no relationship between the atria and the ventricles. They both are contracting, but they're contracting at different rates. So they each have their own rate. Regular P waves and which of the following characteristics should the nurse expect to observe? Regular P waves and QRS complexes occurring at consistent intervals, but independently of each other. So regular P waves and regular QRSs. So if we march out the P waves, they march out. And if we march out the QRSs, they march out. But they're each marching to the beat of their own drummer. The P waves are marching out at the beat of 80 beats per minute. The QRSs are marching out at a beat of 40 beats per minute. That's an example. So they're both marching, but they're marching to the beat of their own drummer, which means independent of each other. So A is a true statement. That's a good description of a complete heart block. PR intervals gradually lengthening until a QRS complex is dropped. That's a wanky block. Prolonged PR intervals without dropped QRS complexes. Well, if there's no dropped QRS complexes, then it's a first degree heart block. Irregular P waves with no consistent relationship to QRS complexes. So the second half of this statement is true, but the first half is wrong. There are regular P waves. A is right because it says regular P waves. D is wrong because it says irregular P waves. Remember, I marched out those P waves. And if you go back and rewatch this video, you're going to see that I consistently march out the P waves so you can see that they do march out. I didn't march out the QRSs, but you could march out the QRSs. They're marching out at a consistent rate. A patient with a third degree heart block, which is a complete heart block, is being prepared for treatment. Which of the following interventions should the nurse anticipate? Administration of beta blockers? Absolutely not. Don't give a beta blocker to someone with a heart block. Administration of atropine? That might help, but it's not what we do for a third degree heart block. Temporary pacing and preparation for a permanent pacemaker? Absolutely. Cardioversion? No, we do that for AFib, A-flutter. So C is the correct answer. It's an emergency. We temporarily pace until we can get a permanent pacemaker in. Which of the following clinical manifestations should a nurse expect to find in a patient with a third degree heart block? Stable blood pressure and heart rate? No, it's an emergency. We're bringing the crash cart into the room for a reason. Rapid and irregular pulse? No, it's a heart block. Heart blocks never have increased heart rate, y'all. Intermittent palpitations with normal heart rate? No, it's a heart block. We don't have normal heart rates with this. Severe bradycardia and hypotension? Yes, that's exactly right. Remember, the pulse that you feel is based on the ventricular rate. And in both cases where we did third degree heart blocks, in both cases, we saw a slowed ventricular rate because the ventricles are in charge of that rate, and so it slows it down. The SA node is firing at a rate of 60 to 100, but the ventricles are probably firing at a rate of 20 to 40. So it's much slower, and that's the pulse rate that you feel. Okay, so I understand if this seemed a little overwhelming to you. If it's too much, y'all, just let it go and do the ones you have to know for NCLEX. But if you are working in an ICU, in an ED setting, or cardiac step down, I was a cardiac step down nurse for many, many years, then this is stuff that you want to know. And hopefully it was helpful to you. So I hope you have a great rest of your day. Good luck. Good luck on your NCLEX.